So we have seen this ARNI, that is angiotensin receptor and neprilysin inhibitors. Here this natriuretic peptides we have seen, and there are inactive fragments which are there, and there is a control of this, that is this natriuretic peptides are actually metabolized with this, that is neprilysin. And neprilysin, if it is inhibited, then this natriuretic peptide can show more action, okay, and because of that the AT1 mediated activities will be less. So this is how this ARNIs are there. Example of this is sacubitril is a prodrug that will inhibit the neprilysin, that will leading to the increased levels of natriuretic peptides, and simultaneously valsartan is combined with that, which is angiotensin 2 receptor blocker. So this combination will decrease the angiotensin mediated actions, and this will cause increase in the natriuretic peptide activity and decrease in the angiotensin 2. What can be the adverse effect? It should be having angioedema, hypotension, impaired renal failure, and hyperkalemia. It should not be administered concomitantly with ACE inhibitors or within 36 hours of the last dose of ACE inhibitor, because that will cause severe action about it. Next are beta blocker. We know about beta blocker, but the problem with the beta blockers is what, or means why beta blockers are useful, rather we shall be seeing it, that whenever heart is failed, whenever there is a decrease in the heart function, then the feedback mechanism will cause increase in the sympathetic activation. Okay, this is because of the baroreceptor, chemoreceptor which are present, and this baroreceptor, chemoreceptor, they will cause the sympathetic activation. Therefore it is a stimulation of or increase in the secretion of or release of adrenergic flow. This will cause increase in the sympathetic activities, maybe beta 1, beta 2, alpha 1 activities, and because of all this it will cause more problem, more damage to myocardium. It will cause increase in the arrhythmias, and because of that it will be more strenuous, it will be having more problem, and it will cause progression of the disease. Further, they will also increase the sympathetic activity to kidney. Because of this alpha and beta 1, there will be activation of renin-angiotensin mechanism that will cause vasoconstriction, it will cause sodium retention. This will also contribute into disease progression, and therefore this sympathetic mediated activities can be very dangerous in the cardiac activity, and therefore beta blockers plays important role to control it. So these beta blockers, but very important, as I repeat, yesterday also I told, I repeat it again, that beta blockers has to be used very, very judiciously. You will be drug expert, you have to think in what condition beta blockers can be used, where beta blockers should not be used. Then next important are the MRAs, that is mineralocortical receptor antagonists. Yesterday we have seen it, and in diuretics just initially we have seen these are having the effects. Aldosterone physiology, last year you might have studied in physiology of urine formation, and aldosterone receptor antagonist we have seen yesterday, we have seen today also, I told you about it. It is spironolactone. So this spironolactone will be acting it, and this is done by many way how we can do it. Angiotensin inhibition can also decrease in the aldosterone, and it is associated with the increase in the myocardial fibrosis, inflammation, myocyte hypertrophy, and apoptosis. And this receptor antagonist MRAs, they will inhibit the aldosterone. We have seen example spironolactone. Then ivabradine is a new type of drug which particularly acts on the hyperpolarization activated cyclic nucleotide gated, that is HCN channel blocker. So these are what are the cyclonucleotides? Cyclic AMP, you know, cyclic GMP, guanosine monophosphate, or adenosine monophosphate. So adenosine is a nucleotide because adenosine monophosphate is a nucleotide that way. So these are the cyclic nucleotide, and they are acting as a second messenger. They can cause changes in the gates. So when the gates are activated and hyperpolarization taking place, so we have got drugs which can be block it. This is the ivabradine. So what will it will be doing? It will be doing the diastolic depolarization slope in the SA node will be reduced. So it will take time in the depolarization, and because of that decrease in the heart rate will be there. Because depolarization slope it is there, that means it will stay longer time depolarized, so it will not repolarize early. So that much is a refractory period. I told you, you read about refractory period and all. So that much will be the refractory period, and because of that new impulse will not be there, no new depolarization will be there, and because of that heart rate will be decreased. It will not uh, have any effect on myocardial contractility and intracardiac conduction. Example, it will reduce the SA node firing. SA node which was firing more earlier, that will be reduced, but it will not affect the conduction from SA node to AV node to Purkinje fiber. So that will not be affected, and this is how it is acting. It is indicated to reduce the risk of this heart failure related hospitalization in the patient with stable symptomatic chronic heart failure with where left ventricular ejection fraction. What is ejection fraction? That when whatsoever heart pumps in a given time, just like you call it as a stroke volume. Okay, so that is in that particularly with dye is mixed, and accordingly it is checked externally. That is called as a ejection fraction. So when the left ventricular ejection fraction is less than 35%, then in that patient it is useful where you cannot use the beta blocker. I told you beta blockers has to be contraindicated in some of the heart failure cases, because pumping has reduced too much, and we have to give rather beta 1 agonist, which are this dobutamine or dopamine. They are used as a positive inotropic agent. So in that cases you cannot use beta blocker. So it is very, very important to check where it is there. Then the combination of hydralazine and isosorbate dinitrate. We have seen both these drugs. Hydralazine we have seen during antihypertensive, isosorbate dinitrate during angina pectoris. Both are vasodilators. Arteries as well as veins, they are vasodilating, and therefore there is decrease in too much afterload and preload, and because of that they are very, very useful. They shows a very good effect where the patient have got left ventricular ejection fraction less than 40%, who cannot tolerate ACE inhibitors or ARBs, that is angiotensin receptor blockers, particularly in patients which are having renal insufficiency or renal impairment. So this is how these drugs are there. If we see the benefits, this benefit actually is a part of your pharmacotherapeutics. That is how various drugs are benefited. I told you many times, I give you example, that example, if you are studying hypertension, you will, in pharmacology you will study so many drugs. Here also you are studying so many drugs, but in what condition, how much benefit one is offering. So there are various kind of research are going on, long-term research are going on. What happened when the patient are given ACE inhibitor or other drugs. So that result shows that around ACE inhibitor ARB shown around 70% reduction in the mortality and 31% reduction in the hospitalization. Beta blocker shows 34% reduction in the mortality, 41% reduction in the hospitalization. While aldosterone antagonists, they decrease 30% reduction in mortality, while 35% in hospitalization. And hydralazine plus nitrate combination, it has shown 43% reduction in the mortality and 33% reduction in hospitality. So these are all good beneficial effect the drug has shown. Digoxin is not having direct benefit on the mortality. It decreases the hospitalization, it increases the exercise tolerance, and it has got good impact on the atrial fibrillation. We shall see detail about digitalis. Then drugs which should not be given during heart failure are the NSAIDs, thiazolidine-diones, then calcium channel blockers, particularly which are non-dihydropyridine. Example, why? Because we have seen non-dihydropyridines are vasculoselective, so they are beneficial. They are acting on what? They are acting on blood vessels, so they causes vasodilation. But other one, example verapamil, it is acting on cardiac one, and it will reduce the force of contraction. Already there is a heart failure, So you should not use calcium channel blocker of verapamil or even diltiazem class. So these are the things, these are very very important thing which you should be knowing, you should be understanding. Then dietary supplements, they are not that benefit. Now various drugs at various stages, this again you will study in therapeutics, but just for your information you can have. At stage A, where are risk is there but symptoms are not there. Why are this? There is the persons which are having hypertension for long period, uncontrolled hypertension, so they are, or obese person, they are more prone to have heart failure. So this is the lowest stage in that, and in that what you can do is you can reduce the risk factor. How you can reduce? Example, you will give the treatment for hypertension, you will reduce the obesity, you will ask the patient to go for diet and other things. So this kind of education you will give, exercise things you will be giving. Then next is treat hypertension, diabetes, dyslipidemia with ACE inhibitor or ARB in some patient. This is initial treatment in the next one. Next to that is ACE inhibitor or ARBs in all patients. Beta blockers can also be given in some of the patients. Then combination of ACE inhibitor or beta blocker, or a combination of ARB or beta blockers. Then next is dietary sodium restriction plus diuretics plus digoxin at the higher stages. So digoxin is when the pumping is reduced too much. Okay. Then cardiac resynchronization of bundle branch patient, that is bundle branch is blocked. If you will study the histology of heart muscle, okay, you will find the branching of that, and these branches are important. I'll suggest you to read the physiology in detail, because it will help you to understand how the currents are flowing, what are various connections between each cell. They are very very important. Then lastly, it is a revascularization, mitral valve surgery. Then other activities are there. Lastly, inotropes can be given at the end, that is dobutamine or dopamine, etc. And lastly, if there is too much damage, then artificial heart or transplantation. These are the ways which are remaining. Okay, so these are the situations where we can have. These are the trials which suggest which drug has to be used at what places. Then inotropes are there. They are indicated in presence of acute or chronic hemodynamic compromise with end organ disem. Because see, important thing is heart is not doing the job. That means it will not able to pump the blood properly. If the pump is not properly pumped, so it will not be received by all the organs properly. If the organs are not received, then they will also have the hypoxia, and because of that hypoxia, this organ will be damaged. So that is called as a end organ dysfunction. So it may be brain, it can be liver, it can be kidney, and these organs, if they are dysfunctioning, then whole body homeostatic system that gets disturbed, and then it can result to problem. So in that case, it is tried, inotropes are used, and efforts are made that it can improve the heart functioning. So these are example of this. Is dobutamine. Dobutamine we have studied earlier. Hello.